I think we shall start. We have enough people in the room. So welcome to our deep dive presentation this afternoon, everyone. And this afternoon we have Dr. Michael Kess who will be presenting for us. And for those of you, oh, sorry, let me get through the housekeeping announcements first. Okay, I'm back. All right, so just remember you can get recordings for these talks on the Blood SA website, and feel free to post your questions or comments in the chat box as we go along. But we will have some time at the end if you want to ask any questions as well. If you want to be added to the mailing list for these talks, you just need to email Melanie Davids. Her email address is here. And you don't need to apply for your CPD points. Those will be uploaded for you. Please remember to fill in the survey at the end of the talk. I think it's important feedback for our organizers, but also for the speakers. They like to know how they've done as well. And constructive feedback, of course. And yeah, so that's the housekeeping rules. And thanks to our management team who makes all this happen for us every week. So for those of you who don't know Dr. Michael Kess, Michael is a clinical hematologist at Netcare River. And he actually did his undergrad training at Tygerberg Hospital before my time here. Michael's involved in clinical trials, including CLL, I know that, and as well as stem cell transplantation. I have recently learned that Michael did his first Cape Town cycle tour this year. So very proud of you, Michael. Well done. And I also believe that Michael has a keen interest in astronomy and astrophotography. So Michael, we look forward to your presentation, but also hopefully forward to some of the photographs that I hope you're going to share with us. Now I'll hand over to you. I'm going to stop sharing now.
Okay, great. Thanks so much, Fatima. I'm just going to share my slides. Fatima, won't you confirm for me that you can see my slides?
Oh, you can see them clearly.
Fantastic. Okay, great. Thank you very much for the invitation. Thank you, AstraZeneca, for being involved in this session. And thank you for inviting me back again this year to talk about CLL. I feel like I very pretentiously named this session "How I Treat CLL" in 2024, like those Blood How I Treat articles. Well, I'm nowhere near that kind of expert level at CLL, but I will share with you what I've come to learn about it. It is an area of interest for me. And this talk would also be better entitled "How I Would Like to Treat CLL in 2024, because a lot of what I'm going to tell you is unfortunately going to be inaccessible for the vast number of patients with CLL who need treatment in 2024. But I want to share it with you nevertheless, because I think we need to think critically and think about the way we're doing things. And I think there is some important new information that I'm going to share with you this afternoon. These are my disclosures. So I have asked Bridget to set up a couple of polls. I always like polls in presentations. I think it makes it a little bit more interactive. Make sure that you stay awake and don't fall asleep because you need to answer a question. So I just want you to find out a little bit about the diversity of this audience. So please answer now. Are you a clinical hematologist, a fellow, a pathologist, a registrar, or a clinician who's not included in the above? Are you a clinical trial coordinator or involved in clinical trials? Are you a nurse? Are you from the pharma industry? And then I apologize to everybody else who I haven't specified. I saw there were quite a few scientists in the audience as well. So sorry for not including a category for you guys. please click Other. And then when you've done that, I want you to just scroll down on the poll. You'll see the next question is underneath there, and that is, what is your current level of knowledge on CLL? So A, stand aside, Paulo Gia, I'm going to be the next Eric president. I know everything about CLL. Or B, I'm fairly confident in managing CLL patients or in my level of knowledge about CLL, but hope to learn one or two new things. I know about CLL, but hope I can learn a lot. I know at least what the abbreviation stands for, or I know nothing about CLL. Okay, so let's give everybody a couple of seconds to answer those questions. Then I'm going to end the poll. Okay, and can you all see the results? Fatima, can you see the results?
Yes, we can, Michael.
Great, okay, so 15% clinical hematologists and 5% fellows, mainly pathologists. Go pathologists. Quite a few registrars as well, and then a few people from the pharma industry and those scientists and admin people and other category. Okay, great. That's very interesting. What's your level of current CLL knowledge? I'm glad to see there is at least one person who thinks they can ask Paulo Gia. And there are very few people who are confident in a thorough knowledge of CLL, and there's a whole lot that hope to learn a couple of new things. I see there are very few people who at least know nothing about CLL. Okay, guys, there'll be some more polling questions later on, so stay with us. Let's launch into the talk. So I gave a talk last year on the current state of treatment at that time of first-line treatment of CLL, and things are changing. But I'd like to say that, sure, always remember that no matter what setting you're working in, whether you're in the state or in the private sector, and no matter what your patient has access to or doesn't have access to, and what the IGHV status is and what the TP53 status, remember that patient factors trump all. And you really need to tailor your treatment to the patient who's sitting in front of you. Remember that CLL is an indolent disease, and patients are going to live a long time. And there are, as we know, there is a significant proportion of patients that when they arrive on your doorstep with a diagnosis of CLL, they may not have an indication for treatment at that stage. And a very large percentage of patients may live their entire lives without ever developing an indication. And even those who do need treatment, when you start treating them, they are going to live a very long time in all likelihood, unless they've got a particularly bad subtype of CLL. So it's really important to choose a therapy that's tolerable for the patient and that considers their comorbidities and their concomitant medications. Patient factors are really the most important thing. I'm going to talk about some updates on some important, what I think might be practice-changing clinical trials. And I do want to say a few words about IGHV. IGHV is not as simple as unmutated or mutated. You need to just look at that report quite carefully, and there are some subtleties. Okay, so let's start off with patient factors. Age is obviously very important. In the days prior to novel therapies being available, we talked about go slow, and no-go in terms of patients' age and fitness for therapies. And that's still very relevant today in selecting a therapy. You need to consider a patient's burden of comorbidities. One example that immediately springs to mind is chronic kidney disease. A lot of the trials excluded patients from treatment with novel therapies when their GFR was less than 30. And there are some other scenarios, and we'll actually deal with one of those in one of the cases to come, where kidney disease can be a problem. And as I've said, it's an indolent disease in most patients, so you really need to consider the patient's preference. Many young patients would really prefer a time-limited therapy than having to take a chronic medication for the rest of their lives, whereas older patients might be more amenable to the idea of taking a lifelong treatment. You need to think about concomitant medications, and that's particularly important with these newer therapies. The BTKI inhibitors have an effect on platelets, which predisposes patients to bleeding. So if you've got people who are on anticoagulation or dual antiplatelet therapy, you need to think carefully about putting them on those kind of treatments. And really, you need to think about what can be accessed realistically. And in state healthcare, there's a very sort of prescriptive list of what's available. And I know that there are some centers that with motivation can get access to immunotherapy at least. And that makes a big difference. For the private patient, it really depends on their medical aid and their medical aid plan. Can they afford to upgrade? These are all important questions that you need to discuss with them. Right, so let's have two cases to start off with. Bridget, you can bring up the next set of polls. The first question is this 66-year-old lady. She's got IGHV mutated CLL. She's got a TP53 mutation. She has ischemic heart disease, and she's just had to have a stent inserted. And she is on dual antiplatelet therapy, and she will be on dual antiplatelet therapy for 6 months. She presented with a non-ST elevation, MI, and in cardiac failure. Her CLL does have IWCLL indications for treatment, so she needs to have some form of treatment. How would you treat this patient? Would you give her continuous therapy with the BTK inhibitor? Would you give her venetoclax and obinutuzumab for 12 months? Would you give her a combination of a BTK inhibitor and a BCL2 inhibitor? Would you give her rituximab and bendamustine? Or would you give her chlorambucil and obinutuzumab? Okay, so take a think about that. And then when you're ready, you can scroll down and look on the polls and look at the second case. The second case is a 64-year-old male patient. And this gentleman has got IGHV unmutated CLL. He doesn't have any TP53 aberrations. However, he is diabetic. And he's got a diabetic nephropathy with a GFR of approximately 30. How would you treat this gentleman? Would you give him a continuous BTK inhibitor? Would you give him venetoclax and obinutuzumab, the 12-month combination according to the CLL14 protocol? Would you give him BTK inhibitor and BCL2 inhibitor combination for 24 months? Or would you give him chemoimmunotherapy, either D or Benda or E, chlorambucil and obinutuzumab? Okay, great. I hope you've all had an opportunity to think about those and to cast a vote. I'll give you a few more seconds, and then I'm going to end the poll. Okay, let's have a look at the results. Okay, so let's look at our first case. So this 66 female patient has, although she's got IGHV mutated CLL, which is good prognostic, she's obviously got that dreaded TP53 mutation. She's got ischemic heart disease, and she's had the stent. And really what I wanted you to note here, the patient factor of being on dual antiplatelet therapy, which she's going to need for 6 months, and also her cardiac risk factors. So I think it looks like the majority of the audience has chosen venetoclax and obinutuzumab. Now, there are concerns about venetoclax and obinutuzumab in terms of its efficacy in the setting of a TP53 mutation. And this lady has a TP53 mutation. Really, the best therapy, if one ignores patient-related factors, is continuous therapy with a BTK inhibitor. But given the bleeding risk with that option, I agree with those who decided against a BTK inhibitor. It's not an absolute contraindication, but certainly dual antiplatelet therapy plus a BTK inhibitor is high risk for bleeding. So I think I'd agree with the venetoclax and obinutuzumab combination. Because she's got that TP53 mutation, chemoimmunotherapy, so either R-Benda or chlorambucil and obinutuzumab would probably be less effective. But let's be honest, for many of us and for many patients, that's all they would have access to. Okay, and then looking at the second case, so this is our 64-year-old gentleman with IGHV unmutated CLL, so adverse prognostic from an IGHV status perspective. He doesn't have a TP53 mutation, but he has got this annoying entity of nephropathy associated with his type 2 diabetes. Because of the nephropathy, venetoclax may be perceived to have a bit more of a higher risk giving it to this patient. I haven't told you what his white cell count is, but if he has a high white cell count, obinutuzumab might also be a problem. So though traditionally in South Africa, for patients who have access to it, probably IGHV unmutated CLL is largely being treated with venetoclax and obinutuzumab, and I see the majority of the audience has selected that option. It's not without its problems. I think for this case, I would be, if I had access to it, I would choose the BTK inhibitor and BCL2 combination for 24 months. But that'll become apparent to you why in the data that I'll present to you later. I think continuous BTK inhibitor therapy is also a reasonable option in a patient who's not opposed to the idea of taking lifelong therapy. I would prefer to try to avoid chemoimmunotherapy in this patient with his IGHV unmutated CLL. But once again, the majority of patients are probably going to be limited to options like that. Okay, great. Thank you very much. There will be some more questions going forward. So really just to say, at the end of the day, it doesn't matter what the IGHV and the TP53 mutation status is. Yes, that's helpful in selecting therapy, but really the most important things to consider the age of the patient and their comorbidities. What is their preference and what do they have access to? I think this is an important slide. Professor Al-Sawaf is the lead author on the CLL14 trial, looking at the combination of obinutuzumab and venetoclax. And he showed this slide. And we're constantly having this debate as to whether optimal therapy is fixed duration or continuous. But I think the really appealing thing about fixed duration therapy is that being an indolent disease, this patient is going to live with the disease for a very long time. Choosing fixed duration therapies gives you the opportunity to briefly treat the patient and to offer them long periods of time off treatment. And everybody wants that. Every patient wants to spend long periods of time off treatment. So if you start with a fixed duration therapy, you can offer a patient a long time off treatment. They may progress at some point, but remember, you need IWCLL criteria to justify second-line therapy. So there could be a long period of time after they progress when they can remain off therapy. One could potentially treat them then with a second round of fixed duration therapy and once again offer them a long time off therapy. If you start with a continuous therapy and then when you have progressive disease, unfortunately, you're going to need to switch to a fixed duration therapy. So that will translate to a patient having less time off treatment. And of course, patients can be on continuous therapy for very many years and shortening their time off treatment completely. But I do agree that there's a subset of patients who needs that continuous therapy. Okay, so we're going to talk about the current state of the art, which I think is important to know about, and it's important for fellows who are participating in the exams. And I think that where we have patients who have access to things, that we need to have this in mind so that we can treat them optimally. But the reality is access is always going to limit us from treating patients optimally. I'm going to talk a lot about adverse IGHV. And I'm using this term adverse IGHV because, as I've said previously, it's not as simple as IGHV mutated versus unmutated anymore. IGHV sequencing often yields a stereotyped BCR receptor product. And that stereotype may be associated with certain prognostic implications. So you do get adverse subsets within the IGHV mutated group. And if they are present, particularly subset 2, then a patient should be treated as though they've got IGHV unmutated CLL because their prognosis is just as bad. But I'll show you a bit more about that later. I'm going to talk about, I use the term TP53 aberration. So that's an inclusive term of both DEL17P and TP53 mutations by sequencing. We're going to talk about time-limited versus continuous. And really, I want to ask the question, based on the data that I'm showing you today, is time-limited therapy good enough for IGHV unmutated CLL? We've already said if a patient has access to continuous BTK inhibitor therapy, and they've got a TP53 aberration, then that is probably the preferable way to go. Up until now, we felt that CLL14, 12 months, venetoclax and obinutuzumab is probably adequate therapy for IGHV unmutated CLL. In a patient who has access to other options, it may not be. Right, so chemoimmunotherapy. Again, it's all about access. It's really hardly used at all in countries with wide access to BCL2 inhibitors and BTK inhibitors. Really, the only situation is IGHV mutated CLL, again, with that proviso that it's not one of the adverse prognostic subsets. But of course, there are concerns about secondary malignancies. CLL8 showed us that in this subgroup of IGHV mutated CLL without TP53 aberrations, 60% of patients are cured by FCR, but how many of them go on to develop myelodysplastic syndrome or acute myeloid leukemia later on in life? So there's a big concern about that. Where it's easily accessible, developed countries are using venetoclax and obinutuzumab predominantly for this subgroup of patients. We can reassure ourselves to a degree by saying that there are very few cases of overall survival differences in these clinical trials. And where there are overall survival differences, they are modest. I always wonder, in a country like South Africa, whether progression-free survival benefit in clinical trials doesn't translate to overall survival benefit, because patients in the developed world have access to virtually an infinite armamentarium of second-line therapies and to clinical trials, which prolongs their overall survival. Patients in South Africa don't always have access to those things. I think that we have to acknowledge that chemoimmunotherapy is unfortunately suboptimal treatment for CLL. And as I mentioned, progression-free survival probably translates to overall survival in our setting. Okay, so just to recap a bit, for those of you unfamiliar with it, the RESONATE-2 study was a study in patients who were older, patients older than 65. For patients between the ages of 65 and 69, they needed to have comorbidities that precluded them from treatment with FCR, and patients with the DAL17P were excluded from this trial. Patients were randomized to receive either ibrutinib once daily until progression, or chlorambucil for a maximum of 12 months. And then they went on to follow up. Crossover was allowed for patients who progressed on chlorambucil. They could cross over to the ibrutinib arm. Now, I think we've all seen many updates over the years of this trial. RESONATE-2 has now been going for longer than 10 years. And at EHA this year, the 10-year follow-up was published. And even from earlier updates to this trial, an overall survival benefit was present. And I think the overall survival benefit in this trial is really significant because of the fact that crossover was allowed. And I think an important thing that this trial also showed was that the adverse prognostic risk conferred by IGHV unmutated CLL was abrogated with single therapy ibrutinib. This graph nicely shows that. You can see that the patients with IGHV unmutated CLL who got chlorambucil did significantly worse, but the two lines for the ibrutinib treated patients are superimposed on each other. This is an interesting slide, and we've seen numerous updates of this over the years for the RESONATE-2 trial as well. And it just goes to show that patients receiving monotherapy with a BTK inhibitor, and in this case specifically ibrutinib, very few of them achieve complete responses. An extremely small number become MRD negative. The vast majority of patients have a partial response, nevertheless, they've got good outcomes and long-term survival. So you don't really need deep responses on a BTK inhibitor to have long-term progression-free survival and overall survival. I think this is really a particularly nice slide, and it shows that these, and this is not just from RESONATE-2, but it's pooled ibrutinib first-line data from other trials as well. And it shows that in patients who were older than 65, who were treated with monotherapy ibrutinib, their overall survival was completely equivalent to age-matched controls. So patients treated with monotherapy ibrutinib essentially have normal life expectancies. Next, we come to the ELEVATE-TN study, TN standing for treatment naive. So this was the registration trial for acalabrutinib in the first-line setting. Acalabrutinib is, like ibrutinib, a covalent binding BTK inhibitor. So the Elevate-TN study was a bit different to Resonate-2. There were 3 arms of randomization. They included younger patients in this trial, but if you were younger than 65, then you needed to be excluded from more intensive therapies by either comorbidities or a creatinine clearance that was low. Treatment naive, and you needed to have a performance status of 2 or better. They did include patients with deletion 17p in this trial, which is interesting because there was a chemoimmunotherapy control arm. So they randomized patients to 3 groups, 1:1:1. It was acalabrutinib plus obinutuzumab, chlorambucil plus obinutuzumab, or acalabrutinib monotherapy. And here I'm showing you a more recent update. This was shared at ASH at the end of last year, the 6-year follow-up for Elevate-TN, and it shows that the progression-free survival of both of the acalabrutinib-containing arms is significantly better than the obinutuzumab plus chlorambucil. What is interesting is that the progression-free survival of the obinutuzumab plus acalabrutinib is increasing. Now, previously, I've shown the results of the Alliance trial, where they compared ibrutinib monotherapy to ibrutinib plus rituximab, and the control arm was bendamustine and rituximab. And in that trial, the two ibrutinib-treated arms, with and without the anti-CD20 monoclonal antibody, were completely superimposed on each other. There was no difference. But we know that obinutuzumab is more effective than rituximab in CLL. So I think it was really a very interesting idea to add it to the acalabrutinib. And here we are starting to see that there is a difference. There is, at this stage, a progression-free survival difference, which is statistically significant between the obinutuzumab plus acala versus acala monotherapy. There is not yet an overall survival benefit by adding the obinutuzumab, but there is an overall survival benefit of A plus O versus obinutuzumab plus chlorambucil in the study. It's a small difference, but again, considering that CLL is an indolent disease, I think that is very significant. Why is it that patients who get the obinutuzumab with the acalabrutinib do so much better? So I think a big part of that has got to do with the significantly higher rates of undetectable MRD that obinutuzumab is able to produce. And here you can see on the left-hand side, 41% of patients in the A plus O group achieved undetectable MRD versus very small numbers in the other 2 groups. So that early, and it happens early that patients become MRD negative appears to translate to those significant progression-free survival benefits. Just to show you that very much like ibrutinib, acalabrutinib also abrogates the adverse risk conferred by deletion 17p, and it does the same with IGHV unmutated CLL. Now we come to our third BTK inhibitor. So the Sequoia study was the first-line registration trial for zanubrutinib, which has recently become available in South Africa. This particular sponsor, BeiGene, they are fond of doing these fairly complex trials where they look at a whole lot of things in a trial. And so this is a considerably more complex trial compared to the previous 2. They actually had 3 cohorts. So for now, I just want you to focus on cohort 1. So as I said, these are treatment naive patients. Similar to Elevate-TN, you had to be either older than 65 or younger than 65, but with comorbidities which made you unsuitable for an FCR-like treatment. They excluded patients with Richter's transformation, which was fairly normal, and those were the stratification factors. And cohort 1, they excluded DAL17P. Interestingly, they didn't exclude TP53 mutations. So there were some patients with TP53 mutations who were included in this cohort, and they were randomized either to zanubrutinib, 160 milligrams BD, or bendamustine and rituximab. They received 6 cycles. They then did a second cohort. They wanted to be able to treat patients with DAL17P, but they didn't want to give the patients with DAL17P chemoimmunotherapy. So this was really a single-arm cohort, just patients treated with zanubrutinib but specifically those who had DAL17P. And then they had a third cohort that they offered patients combination therapy with zanubrutinib and venetoclax. But I'm really going to focus on cohort 1 here. And once again, just to show you that that zanubrutinib treatment virtually completely abrogates the adverse prognostic effect of IGHV unmutated CLL. So these these two lines are virtually on top of each other. This difference has not yet become statistically significant, but it'll be interesting to see what happens in the future. An excellent long-term, both progression-free and overall survival in that adverse prognostic DAL17P group with monotherapy zanubrutinib. Right, so the question is, if we look at progression-free survival between these different options, do we have a winner at this stage? So RESONATE-2 had a progression-free survival of 74% at 4 years, acalabrutinib 78%, so those numbers are pretty close together. But look at that significantly difference. Now, again, this is an intertrial comparison, which everybody tells you never to do, but given that there are no direct comparisons at this stage, this is what we have to do. An 87% progression-free survival at 4 years with the addition of the obinutuzumab. Zanubrutinib, slightly shorter follow-up to look at that progression-free survival, but I think very similar to the other BTK inhibitor monotherapies. Right, so continuous therapy in the first line is associated with the improved progression-free and overall survival. But unfortunately, the implication is that you have to give this patient this treatment forever, either until their disease progresses or they develop intolerable side effects. But if they don't, you keep going. These treatments produce low CR rates and low undetectable MRD rates. But as I've said, how important is that? They do well, they have long progression-free survivals, they have long overall survivals. Really, the major disadvantage is the fact that it's ongoing therapy forever. They are well tolerated in general, but I'm sure we've all seen patients with invasive fungal infections on BTK inhibitors. They are not innocuous. We know about the bleeding risk, we know about the atrial fibrillation risk, we know about the hypertension risk. Is there not perhaps a way that we can give patients more time off therapy safely? Unfortunately, it is thus far the only strategy really proven to provide the greatest benefit in terms of abrogating the risk of TP53 aberrations. So that's currently where we like to use it. But what about fixed duration strategies? Can we do better than what we currently are? So I'm going to start with the CLL14 study. I've mentioned this a couple of times. For those of you who are unfamiliar with it, it is a first-line study in CLL. Again, patients with coexisting conditions and with mildly impaired renal function only allowed, and patients were randomized to either receive a combination of obinutuzumab and venetoclax or chlorambucil and venetoclax. This is the 6-year update that was recently published, and you can see that venetoclax and obinutuzumab significantly outperforms chlorambucil and obinutuzumab, median progression-free survival of 76.2 months versus only 36.4 months in the chemoimmunotherapy arm. Now, in South Africa, for patients who have access to this combination, we have felt that IGHV unmutated CLL is appropriately treated with venetoclax and obinutuzumab. But the 6-year follow-up demonstrates that the survival curves are separating further and further in this particular high-risk subgroup. So the difference between IGHV mutated CLL and IGHV unmutated CLL is becoming significant. And at 6 years of follow-up, only 43% of patients with IGHV unmutated CLL have not yet progressed. So I'm adding a bit to this table here just so that we can continue looking at different options. 55% at 5 years progression-free survival. This trial is a phase 2 study that was done at MD Anderson. It was published for the first time in 2019 in the NEJM because of some very exciting MRD negativity results. I'm going to show you today the longer term outcomes. So These patients were treated with venetoclax and obinutuzumab for at least 2 years. They had a 3-month ibrutinib run-in before the venetoclax was initiated, and the idea was to debulk patients and to reduce the risk of tumor lysis syndrome at the time that the venetoclax was commenced. Patients included in this trial all had a high-risk feature of sorts. They either had a TP53 aberration, or they had a DEL11Q, or they were IGHV unmutated CLL, or they were older patients. This is the publication from 2019 in the NEJM. And what it showed is that over time, with this longer-term treatment, patients' MRD levels continued to deepen. And this was tremendously exciting. These are the longer term, the 5-year follow-up data, progression-free survival of 90.1% and an overall survival of 95.6%. This is really remarkable outcomes given the high-risk population of patients that was included in this trial. So here we can put venetoclax and ibrutinib. I've put 2 years there, but strictly speaking, patients continued therapy for longer. If they were MRD positive at the end of the trial, they could continue ibrutinib monotherapy. So it's not strictly speaking 2 years and then stop, but patients were treated for at least 2 years. Most patients did come off therapy. And the 5-year progression-free survival in that high-risk IGHV unmutated group was 90%. Next, I'm going to show you some updated results from the Captivate trial. The Captivate was also a multi-center phase 2 trial. It also looked at this combination of ibrutinib and venetoclax. Really, they wanted to look at some outcomes associated with MRD. So there were 2 cohorts. All patients included in the trial were initially treated with 3 cycles of ibrutinib, followed by 12 cycles of ibrutinib and venetoclax. So an initial similar start to the MD Anderson trial I just showed you. But initially, these patients really were only treated for 15 cycles, 3 cycles of ibrutinib and 12 cycles of combination with ibrutinib and venetoclax. They then underwent an MRD-guided randomization. So if they had confirmed undetectable MRD, they were randomized to receive either placebo or ibrutinib. If undetectable MRD was not confirmed, they were randomized either to receive ibrutinib monotherapy or to continue on the ibrutinib and venetoclax therapy. And these are the updated 5-year results. And here you can again see that there is a separation occurring between the mutated IGHV CLL patients and the unmutated IGHV CLL patients. This analysis excluded patients with those DEL17P and mutated TP53 and complex karyotype features to try to correct for IGHV mutation status as a factor on its own. So the majority of these patients really only got treatment for 1 year. So again, if you limit your therapy to 1 year, then you again see this lower 5-year progression-free survival. Next, I'm going to show you the FLAIR trial. So the FLAIR trial had 3 arms. It had a control arm of FCR, standard FCR, patients treated for 6 cycles and then followed up with MRD assessments. There was a monotherapy ibrutinib arm. Patients continued to a maximum of 6 years with ibrutinib monotherapy. All patients were given ibrutinib and venetoclax. Now, this was again an MRD decision-made guided trial. So the duration of the ibrutinib and venetoclax therapy was determined by the time that it took for patients to reach MRD negativity. Essentially, the patient continued on therapy for double the amount of time that it took them to achieve MRD negativity. But they had to get at least 2 years of treatment. They were allowed a maximum of 6 years of treatment if it took them 3 years to get to MRD negativity. And these are the results. So you can see the massive difference in progression-free survival between the patients who received FCR and the I+V combination. The overall survival is modest, but nevertheless statistically significant between those arms. Patients with mutated IGHV, virtually no difference between the outcomes. in those arms, either in terms of progression-free or overall survival. Patients receiving monotherapy with ibrutinib, virtually none of them achieved undetectable MRD, either in blood or marrow, whereas there were high rates of undetectable MRD in patients with I+V, both in peripheral blood and bone marrow. So if you look at that subset of IGHV unmutated patients treated on the FLAIR trial, they had achieved a 98% progression-free survival, not quite 5 years, but at 3 years. Longer follow-up is needed to decide. As I said, everybody received at least 2 years, but there were those who went on to receive up to 6 years of treatment. Then I'd like to show you an update to the GLOW trial. So the GLOW trial was also first-line treatment with CLL, older patients with CLL, or those with comorbidities, because they were comparing to a chemoimmunotherapy control arm. They excluded patients with TP53 aberrations. Patients on the study arm were treated with ibrutinib and venetoclax, very similarly to the I+V combinations we've seen thus far, with a 3-cycle monotherapy leading with ibrutinib, followed by ibrutinib plus venetoclax combination, again for 12 cycles. Patients treated with obinutuzumab and chlorambucil received treatment for 6 cycles. And here this is the most recently updated data, 57 months of follow-up. And we can see how these curves separate. And you can see, again, I just want to actually draw your attention to these top 2 curves, patients with IGHV unmutated CLL getting that ibrutinib and venetoclax combination, doing significantly worse than patients with mutated IGHV CLL. Again, we see a similar result when we look at the CLL14 and the Captivate trials. So if you give combination therapy for just 1 year, then unfortunately you're going to have significantly lower 5-year progression-free survival rates. It seems like giving combination therapy, particularly for this high-risk subgroup of IGHV unmutated CLL, it is important to do it for at least 2 years, possibly longer, but we need more time to answer that question. But I really think for IGHV unmutated CLL, for patients who will have access to a venetoclax plus ibrutinib combination, that's what you need to do for them, and you need to try to do it for at least 2 years. Why don't we give Ven-G to 12 months to patients with TP53? I think most people know the answer to that question, but for those who don't, really it's about the subgroup comparisons from the CLL14 trial. So I just want you to look at this middle graph to begin with. So patients who had TP53 mutations had a 3-year progression-free survival of only 60%. When you look at Sequoia and Resonate-2, those 3-year progression-free survivals are in excess of 80%. So that's the main reason why people have moved away from using Ven-G for patients with TP53 mutated CLL. That is, of course, for those who have access to other things like continuous BTK inhibitor therapy, and who don't have a patient factor that would preclude you from wanting to use continuous BTK therapy. Okay, right. Let's see what you think of what I have said. Bridget, this is the next section with some polling questions. So if you could bring those up for us. I think the questions are all grouped together in the poll again. So if you've answered the first one, scroll down and go on to the next one. So going forward, regardless of access and patient factors, how would you prefer to treat patients with TP53 aberrant CLL? Would you give them a continuous BTK inhibitor? Would you give them venetoclax and obinutuzumab for 12 months? Would you give them a BTK inhibitor plus a BCL2 inhibitor for 24 months? For example, the MD Anderson or FLAIR trials that I've showed you, or would you give them chemoimmunotherapy? So have a look at those options now and enter your vote. Once you've answered the first question, scroll down to the second question and have a look at that. Going forward, how would you prefer to treat patients with IGHV mutated CLL? So no high-risk subset, This is good risk CLL. Would you give them a continuous BTK inhibitor? Would you give them venetoclax and obinutuzumab for 12 months? Would you give them BTK inhibitor and BCL2 inhibitor for 24 months? Or would you give them chemoimmunotherapy? Okay, and when you've had a time to look at those, go on to question number 3. Question number 3 is, going forward, how would you prefer to treat patients with IGHV unmutated or IGHV mutated CLL with the subset 2? I haven't yet told you about the subset, so that's a bit unfair. But for those of you who know, would you give them continuous BTK, venetoclax and obinutuzumab 12 months, BTK and BCL2 24 months, or chemoimmunotherapy? Okay, we'll give everybody a few more seconds, and then I'll end the poll and we can have a look at the results. Okay, let's take a look and see. So we've got some seriously split votes here. General principles. Going forward, how would you prefer to treat patients with TP53 aberrant CLL? So I think if you disregard any particular patient factors and disregard access, then I would probably agree with the people who chose continuous BTK inhibitor therapy. I think loads of patients are opposed to the idea of continuous therapy and want lots of time off treatment. And certainly that's a situation where the 12-month might work. But bear in mind that significantly shorter progression-free survival that we see in that group, 60% versus 84% and 81% in the Resonate-2 and Sequoia trials, respectively. So you are going to sacrifice some progression-free survival advantage there if you give them that. I put BTK inhibitor and BCL2 for 24 months because we really don't know. I'm really hoping that the people who chose that option are going to turn out to be right. It would really be fantastic. But I have an idea that when it comes to TP53, it's about duration of therapy and not necessarily the agents that you use. But anyway, we'll obviously grow up and learn that. Okay, thanks for your responses. Then question number 2, general principles. Going forward, how would you prefer to treat patients with IGHV mutated CLL, no high-risk subsets? And the vast majority have chosen venetoclax and obinutuzumab 12-month strategy, and I wholeheartedly agree with that. I think that's really an important place for that. Where patients don't have access to that, then FCR is an appropriate option. So I think chemoimmunotherapy is a good second choice here as well. We worry about secondary malignancies with that approach, but where you don't have access to venetoclax and obinutuzumab, I think that's a perfectly reasonable option. I think there's good data to show that continuous BTK inhibitor therapy is good for any subtype of CLL. So if you've got a patient who's amenable to that kind of strategy, then I think that's the way to go. I do wonder whether BTK inhibitors and BCL2 inhibitors in the longer term aren't going to yield better results in this subgroup as well, but that remains to be seen. But I think I agree with the majority here. Venetoclax and obinutuzumab in this setting is the appropriate option. Okay, and then question number 3, going forward, how would you prefer to treat these adverse IGHV subgroup CLL? And I'm glad to see that lots of people were looking at my slides. I'm glad to see that you agree with me. You may have seen these slides already, this data already, and be convinced. But I think that there are still some people who would say continuous BTK inhibitor therapy. And I think Resonate-2 showed us very nicely. Elevate-TN also showed us very nicely that monotherapy with the BTK inhibitor in the long term also completely abrogates the adverse prognostic risk. You're sacrificing the opportunity to have time-limited therapy, but certainly patients are going to do as well. And perhaps for the older patient who's quite happy to take medication long-term, that's a reasonably good option. I think the fact of the matter is most of the patients that we are going to treat here in South Africa are only going to have access to venetoclax and obinutuzumab at best for this subgroup. But I do think for patients who've got access to more, we may be doing them a disservice by treating them with venetoclax and obinutuzumab. Okay, great. I noticed that there were some questions in the chat. Oh, okay, people were struggling with getting access to the poll. Okay, we're done with the polling question. So my conclusions from looking at this data, I think BTK monotherapy will likely remain the mainstay for TP53 aberrations, but we need longer readout on BTK and BCL2 fixed duration therapy to decide. Where I am unlimited by access, I think I'd choose acalabrutinib and obinutuzumab. It really does seem to be significantly advantageous in terms of progression-free survival, except of course for reimbursement challenges. Venetoclax and obinutuzumab would be my first choice for patients with IGHV mutated CLL, but where you don't have access, chemoimmunotherapy is quite reasonable, but it's probably not quite as good for IGHV unmutated CLL. But of course, the proviso there is where you have choices and where you have the option to give the ibrutinib and venetoclax or BCL2 plus BTK inhibitor combination. I think ibrutinib plus venetoclax would be my first choice for IGHV unmutated CLL or for adverse prognostic IGHV mutated CLL, but reimbursement may be a challenge, especially over longer than 2 years. But perhaps one could make an argument with funders that this time-limited combination is probably more cost-effective than continuous BTK inhibitor therapy. Given the acalabrutinib safety advantages demonstrated in the ELEVATE-RR study over ibrutinib, I think that once there is a data readout on the acalabrutinib plus venetoclax combination that will come from the AMPLIFY trial, for those of you attending ASH at the end of the year, please go and look at the updated AMPLIFY trial results. I can't go to ASH, so I'd like you to come and tell me what it shows, but I suspect that that may gradually over time replace I plus V as the optimal combination. Okay, I wanted to just say a couple of words on reading your IGHV mutation report. Back to basics for a second. Remember that somatic hypermutation is good. I always found it challenging trying to explain to internal medicine registrars. They've had it drummed into their minds. When something is mutated, it's bad. When something is unmutated, it's good. But IGHV is the opposite scenario. We want that IGHV gene to undergo somatic hypermutation. So that's why IGHV mutated CLL has a better prognosis, and IGHV unmutated, more undifferentiated and biologically more aggressive. That's a vast oversimplification, but essentially what it comes down to. Just a word on stereotypy. So IGHV genes are being sequenced by thousands of labs worldwide now. ERIC, what used to be called the European Initiative on CLL, they have now changed their name to Education and Research Initiative on CLL to try to be more inclusive. They run a global program to help laboratories set up and validate both IGHV testing and sequencing for TP53 tests. There are now 80,000 different stereotyped IGHV sequences in the ERIC library, and labs who are affiliated to ERIC and accredited by ERIC, like Oncolab in Pretoria and like Unistel here in the Western Cape. I am uncertain whether the other laboratories in South Africa are ERIC accredited or not. They don't appear on the ERIC website, but I know sometimes these websites are slow to be updated. It's very important wherever you send your IGHV mutation testing, whichever lab you send it to, make sure that that lab is ERIC accredited. Some of these 80,000 stereotypes do have prognostic implications. Many don't, but ERIC now requires that the subset is reported and the prognostic implication is reported of that. So it's not just about unmutated versus mutated. ERIC recommends this cutoff of 98% germline homology. So if a sequence product has greater than 98% germline homology, it is unmutated. If it has a less than 97% homology to the germline gene, then it's clearly IGHV mutated. But there is this gray area between 97 and 98%. Then there are all sorts of tests that the laboratory has to do. Check the transcript is productive. Check for other certain mutations which can cause problems. Sometimes a retest is required. But certainly in these gray zone areas, it's always safer to consider that a patient is IGHV unmutated and rather treat them as such. But check with your pathologist and your sequencing lab. And then check for reported subsets. So the laboratories will put on their laboratory report below the outcome of whether it's IGHV unmutated or mutated. if there is a distinct subset associated with this. Subset 1 has an increased frequency of Notch1 mutations, which in turn may lead to a higher frequency of Richter's transformation and biologically more aggressive disease. The impact is not so significant that people feel strongly that these patients should be treated any differently. However, subset 2 has been very clearly defined to be biologically more aggressive, despite most cases associated with subset 2 being IGHV mutated CLL. These kind of patients you should consider prognostically equivalent to IGHV unmutated CLL. Subset 8 is associated with the highest chance of Richter's transformation. So I'm going to just show you some graphs to show you the association. So this thick black line over here represents IGHV mutated CLL in general. This thick gray line represents IGHV unmutated CLL, and the blue line represents subset 2. And you can see that these patients' cumulative survival is essentially equivalent to patients with IGHV unmutated CLL, and hence that recommendation from Eric. So look out for that subset T2 on your IGHV report. Subset 8, amongst different IGHV subsets, has an extremely strong association with Richter transformation. So the question is, do we treat these patients any differently? That's difficult to answer at this stage. More data will follow, but certainly keep your eye out and have a higher index of suspicion for Richter's transformation in the clinical, where the clinical scenario is suggestive of that. And then before I end off, I just wanted to make mention, yes, in South Africa, access is limited. There are loads of challenges, both in the private sector and the public sector. The majority of patients in the private sector are on limited medical aid plans, which make access to things like continuous BTK inhibitor therapy difficult. There are a number of active clinical trial centers doing trials in hematology, and these 5 centers are all doing CLL trials. The 3 CLL trials that are currently recruiting for patients are these listed on the right-hand side of this slide. The second one is a second-line CLL clinical trial. Phase 1, part 1 of this trial has closed. Part 2, unfortunately, will only be open in 2025. So please, next year, if you do come across a patient who needs second-line treatment with CLL, contact your closest center and inquire as to whether a patient can be enrolled in the second-line trial. MK102, 26008 and 011 are both open and actively recruiting patients currently. If you have a patient who doesn't have access to BTK inhibitors on their medical aid, or because they are a patient in the public sector, then please refer them for a clinical trial. These trials offer them the potential to have first-line therapy with a BTK inhibitor. And that brings me to the end. Thank you very much for your attention. 5 o'clock. That's fortunately didn't go over time. Okay, I see that there are some questions in the text. Andrew MacDonald asks, question 1, place for prophylactic antibiotics or antivirals in novel therapies. So yes, I absolutely agree with that, Andrew. I think that BTK inhibitors have been purported to be relatively safe, but we all know they are not innocuous. We have seen patients with getting significant infections, and personally patients getting monotherapy with the BTK inhibitor on a clinical trial. I have been using prophylactic antibiotics and antivirals, and there was a good talk at Eric recently which advocated doing the same. And then Andrew asks use of azoles to dose reduce drugs and the costs. So I think we've all had that discussion, and it's very interesting. Andrew pointed out, and recently the Department of Clinical Pharmacology at Tygerberg confirmed for us that we were reluctant to dose reduce ibrutinib with azoles or other CYP3A4 inhibitors because the relationship in terms of the drug interaction was not as predictable as what it was, for example, with venetoclax, which we were quite comfortable to do that. It would appear that zanubrutinib has a different relationship with CYP3A4 to ibrutinib, and it does appear that the relationship is more predictable. So that is certainly something that one could consider. And then his third question was about the ethics or utility of the current trials still using chemoimmunotherapy as a comparator arm. I think that's really a very good point. And I think that there's loads and loads of data that demonstrates that it's not just TP53 aberrations that confer an adverse prognosis. It's also patients with IGHV unmutated CLL. We've now gone as far as to say that venetoclax plus obinutuzumab may not be the optimal treatment where other options are accessible to a patient. So I think that the ethics of using chemoimmunotherapy as a comparator arm certainly needs further attention and further discussion. Thanks for your questions, Andrew. If anybody else has a question, you're very welcome to post it in the chat. You're very welcome to switch on your microphone and ask directly as well if you'd like to. Fatima, do you have any questions?
Yeah, thanks for that, Michael. I think you presented the data very well, and I especially liked your table, which I think is very useful for the fellows doing exams now as well. As a comparison, so many new drugs to remember, and we don't use them in the state sector, obviously. So nice to have it summarized. Yeah, I mean, I think the thing about chemoimmunotherapy for us in the state sector and being compared in clinical trials may be not so much an issue for a patient coming from the state sector getting into a clinical trial, because they wouldn't receive anything in the state sector. Just to add to Andrew's question, and I think Andrew also mentioned the risk of infections and the need for IV immunoglobulin in patients on chemoimmunotherapy, and certainly in our setting also the use of the T-cell depletion and CD4 lymphopenia, so the need for prophylaxis in patients on fludarabine as well. I just wanted to know whether you see us ever getting access to these drugs in the state sector, and whether these prices will ever come down in the near future. Yeah, what's your comment on that?
Yeah, so I mean that's really the big thing. I think that the days of generics are not far away. One of the speakers at ERIC was from Argentina, and the South American countries have a similar kind of situation to ours. They have this mix of public and private healthcare. The majority of people access public healthcare in Argentina. There's a small percentage. They actually have an ibrutinib generic available in Argentina. So a huge number of their public sector patients are getting access to that ibrutinib generic. Now, there's a lot of questions, and a lot of questions were raised at ERIC about the control of that specific generic and the quality, and were patients being treated appropriately with that question, with that therapy. But it was interesting to see that there is access to something like that. So I think fortunately the days of access to generics are not too far away, and that will hopefully change access in the public sector.
So we remain optimistic about that. And just one more question based on that, because our treatment may not differ too much in the public sector, the utility of looking at the TP53 aberrations or mutations and 17p deletion, which we do that routinely, and the IGH mutation status, how would we fit that into our daily practice?
Don't do a test if you're not going to change your treatment based on the results. I think that's a very important question, and particularly in a resource-constrained environment where you need funds for other things. So is it worth doing those tests if you can't act on the results? I think that's a very relevant question. I think the one situation perhaps where it might still be valid, if you've got a young patient who doesn't have comorbidities, who might be eligible for an allogeneic stem cell transplant, knowing that they have a TP53 mutation might prompt you to refer them for evaluation for a stem cell transplant at an earlier time. So I think that certainly might make a difference. IGHV unmutated in the absence of a TP53 mutation, sure, they still live a long time. Even if you give them chemoimmunotherapy, they do have shorter durations of responses, but I certainly don't think an allotransplant is justified if that's your only high-risk feature. So yeah, I would advocate for doing the TP53 in younger patients, but I think you make an excellent point. Why do a test if it's not going to influence your decisions? It does give you prognostic information, which patients are often interested in. Yes.
No, absolutely. And I think that's also important for counseling of patients as well. Since, especially with an indolent disease, patients always want to know what to expect in the future, etc. So I find that useful with NGS, for example, even though it may not change management too much in certain conditions for us. But yeah, that's certainly something to consider. So I see we do have a comment from Dr. Gupta, fellow from Zim. Unfortunately, we don't have access to the new therapies in Zimbabwe. How can we have our patients access these, or can they be involved in clinical trials, Michael?
Yeah, absolutely. I think, sure, it does make it difficult for a patient to travel all the way from outside the country to come and participate in a clinical trial. I know that we do treat patients on clinical trials from very far away, but certainly I can find out for you and get back to you on that one. See, Andrew also has his hand raised.
Oh, sorry, I can't see that. Andrew, do you want to go ahead?
Yeah, so just a couple of things. Just to answer that question, I mean, look, I don't think there should be a problem getting patients from other countries. The big issue is going to be the transport. I mean, we do, some clinical trials have flown people from the centers across the country. So it's not, I think, the money in terms of flying. It's going to be, you know, the frequency of visits is, and depending on the exact trial that the requirements for there. So I think it's not impossible, but I think it's going to be difficult. But I think the right patient, the right setting, we could look at it. Just a comment, Michael, on your comment about TP53. So yeah, I absolutely agree. If you don't have any other option and you've got access to a young enough patient who's got a transplant option in state, yes, absolutely, that's the patient you would consider. But I mean, conversely, if you do have access to novel therapies, I mean, we always used to say TP53, especially up front, and now they're requiring therapy, they should go for transplant. But there's actually no data that transplant helps those patients, especially now with the good outcomes of long-term BDK inhibitors. So I've certainly got a couple of patients now who are first-line TP53 mutated, who are on BDK inhibitors, who I'm not even really considering transplant, even though they potentially could, or are young enough and fit enough to go for transplant.
Yes, absolutely. Don't misunderstand. I'm not advocating transplant as an option for patients with.
Yeah, no. I think it's just a converse. It's what you have available, and absolutely. I mean, your comment was entirely fair, but it's just the reverse is also not. It depends on what you again.
For sure. Andrew,
Oh, sure.
in the age of novel therapies, do you think that transplant still has a role at all for patients with CLL?
I do. I mean, I still think there's a couple of patients who really are progressing, even on sort of like, you know, you've had BDKs and have had obinutuzumab, and then Richter's is I mean, whether the transplant is effective in Richter's is a whole different question. But I mean, I think there still are patients. We're doing much fewer, but I mean, certainly I think there is still a place for it in the future. Maybe not, but we're still considering. But again, we also have issues with access. I mean, it's just because we're in state and also have access to clinical trials. I mean, and just not like everybody gets what we would like them to get. So again, back to transplant. Yeah. Just one other question. Sorry, another comment. Sorry, and I'm hogging the floor now. I think the big issue for state is going to be this lack of, you've got a TP53, and that would be the classic case in the old days where we would have considered alemtuzumab. But I mean, of course, now with the alemtuzumab issue, that has really kind of been taken away. I'm not sure if you guys, if the state have any access to it. I mean, the transplant has become an issue, but I'm not sure what the CLL situation is. Be interesting to hear, but I'm assuming it's the same, and that access is now really very limited.
I must admit, we haven't used it in CLL at Tygerberg. I don't know if anyone else has. Jacques, have you tried to access Campaign? Alemtuzumab?
I have been successful a few times recently, actually, in getting alemtuzumab, but it was with a big fight for state patients. So, yeah, we have used alemtuzumab for TP53 mutated patients, but few and far between. We tend to go, one option is high-dose methylpred can induce responses, but it's usually not very long-lived. So, yeah, they remain a big problem in state.
And then I see there was another question. What did somebody say? Fiona, what do you think newer therapies could lead to patients being treated earlier than the current CLL working group criteria recommend? Michael?
Not outside of a clinical trial. I know that the German CLL study group was doing a high-risk asymptomatic CLL clinical trial. I haven't seen the results of that yet. So no, I don't think so at this stage. I think Jacques also responded and said only based on IWCLL criteria. Most clinical trials that we're participating in require the patients to have IWCLL criteria for treatment. But yes, there are trials looking at that. It'll be interesting to see what happens in the future. I think Jacques also rightly points out there novel therapies still have toxicities, and some patients can go for years without therapy. So why expose them to any risk of toxicity when they don't need therapy?
Jacques makes a point here where he said he also uses the TP53 mutation 7P to rationalize the use of rituximab in his CLL patients. So the converse, which makes sense as well. Okay. Questions or comments? That then it leaves me just to thank you, Michael, for an excellent presentation and really making sense of a topic that's evolving so quickly in terms of the treatment modalities, etc., and keeping up with the trials as well. So thank you very much for taking the time today. And please remember to fill in the survey at the end, everyone. And thank you. Bye.
Thank you, Fatima.